So we welcome you all to this master class which on endophthalmitis. I wish we had a little bit more crowd for it to become more interactive. I was personally, actually, we all revere Dr. Das, and Dr. Das has been my teacher. Dr. Savitri was my teacher in Pondicherry, and I revere him a lot. He has done so much work in endophthalmitis that wherever he is presenting anything of endophthalmitis, I am there. So I wish a lot of people could have benefited from this course. So the presentation for this course goes.
Should I outline the course? Okay, let me outline the course. Okay. Hello, I am Tara Prasad Das. The master course of managing acute bacterial endophthalmitis is designed by some of us, Ajay Arora, Jobita Joseph sitting here, Lalit Verma, Namita Sharma. So we will have some presentations, but more important, we'll have a panel discussion. Panel discussion will also have slide presentation. So I will start with how to measure disease severity, because when you say endophthalmitis, how do you measure it? By mild, moderate, severe, or by days, or by organism, or something like that. So it will be followed by Jovita talking about microbiology. And microbiology between then and now has improved a lot. Technique has improved a lot. It will be followed by two more talks by me on evidence-based recommendations. We had one earlier randomized controlled trial. We have recently concluded one more randomized controlled trial, and also we'll speak about decision making. More importantly, Lalit and Ajay will speak about different controversial subjects. Example, how do you manage a culture negative endophthalmitis? Or what is your choice of treatment to prevent endophthalmitis, particularly intracameral injection? Because when we did a survey in 2017-18, 41% people in India did not agree to give or did not give actually intracameral antibiotic or use prophylactic povidone. So things changed. So we'll begin today. Hopefully Namrata and Lalit will join. Let me begin with my presentation called How to Measure Disease Severity. In one presentation, I had all three things. So I will present one, then go to next one, then come back to mine. And my presentation will be always a brief so that I have more time to discuss. Since there are less people, advantage that each one of you can ask many questions to us.
Dr. Jovita, why don't you come?
Okay, can I show it there? Right. How do you measure actually your disease? One, we can measure by time. You can call acute if it happens within 6 weeks of event, like this cataract surgery. Doesn't matter whether it's a SICS or phaco emulsification. We have delayed after 6 weeks. Now the time of 6 weeks is actually, believe me, arbitrary, because many years ago, BGO published it by some of those stalwarts in endophthalmitis management. So somehow world agreed to become 6 weeks, but then you can make it 4 weeks, you can make it 8 weeks if you want. But certainly we called mild, moderate, and severe by the vision. Vision is more than 2200, that means 660 in our channel chart. We call it mild. Moderate if it is up to hand motions, then severe if it is light perceptions or less. Certainly by microorganisms, since we talk mostly about the bacteria and fungi, we talk about the gram-positive or gram-negative bacterial infection or a fungal infection, whether it is a filamentous or yeast. And finally, we talk exogenous, endogenous by mode of entry. All traumatic endophthalmitis has to be exogenous because it happens after trauma. Intraocular surgery, not extraocular surgery, also can cause exogenous endophthalmitis. Endogenous is all from the body spread, whether it is a cancer, immunocompromised patients, body septic, or carditis. These are some of the examples. In the left, to your left panel, we see a, so we call it a mild infection. Why? Because there is a huge amount of vitreous anterochamber fluorescent cells. We can see a small amount of it working here. There is actually a membrane. You can see a little gap here. Membrane is forming or breaking out. In the right is a very severe, no light perception, extended to the sclera infection, gone out. Most probably you can't do nothing to this eye, as called the very severe endophthalmitis. As you told that mild are always anterochamber cells and flare, hypopyon will be there, could be there, but less than a millimeter. In the moderate, vision is 2200, and then we'll have a vitreous exudate start appearing in moderate endophthalmitis. Severe, the dense vitritis usually happens in a fungal infection, and there is no fundus view. Anterochamber might be full of hypopyon, and you may not see a red glow also. And very severe is scleral extension, as we showed you. Functionally and structurally, you can also divide endophthalmitis based on the present visual acuity. That is what EVS endophthalmitis vitrectomy study used. That they say that if it is a treatable endophthalmitis by vitrectomy when the vision is hand motions or less, and injectable by different antibiotics, they selected ceftazidime and vancomycin for when vision is hand motions or more. Structurally, based on the involvement of ocular tissues, whether it is a cornea, iris, anterochamber, vitreous, and retina, like this. We designed something else called the inflammation score that combines both structure and functions, and then use it in our own randomized clinical trials. We'll talk in the next presentation, called the endophthalmitis management study. To measure the inflammation, we designed many years ago, in 1999, published in British Journal of Ophthalmology, about how to objectively score the inflammation associated with endophthalmitis. We divide into 4 ocular structures: cornea, anterochamber, iris, and vitreous. Each one has got 2 components. Example, cornea has got corneal edema and abscess. Anterochamber has got flare cells or hypopyon fibrin. Iris has got new vessels in the iris or exudates over the iris, and vitreous has got a flare and opacity. Each one divided into 0 to 4 scale, where 0 means all good and 4 means all bad. It can have so happen that supposing you take cornea and there is so much of corneal abscess or corneal edema that you can't go beyond, you can't examine iris, anterochamber, iris, and vitreous, then you have to give a higher score. That score is below shown in below highlighted, that you add some numbers. So those numbers are at 20, at 15, depending on or 10 or 5. This was a modified version of a paper published by Travis Meredith many years ago that was done on STAP epi rabbit model of endophthalmitis. This is modified that for human use, and this is being used very successfully. And by that, you can actually divide the endophthalmitis by inflammation score into mild, moderate, and severe. We decided that mild endophthalmitis is one where your inflammation score is less than 10, 1 to 9. Moderate is 11 to 19, and severe is more than 20. By that definition, we have shown some pictorial. One, the most left has got a nearly clear, no corneal edema, nearly clear iris, little hypopyon, and some membrane over the iris, and the inflammation score is 6. We call it a mild. There is a surgical implication of that, of why we are talking mild, moderate, severe, or inflammation score between below 9 up to below 19 or above 20. Similarly, the middle one, we have an inflammation score of 12. We call the moderate, and last one is a severe inflammation. Called endophthalmitis of a more than 20 inflammation score. Before we started our endophthalmitis management study, we also did a revalidation of what we have published before, and before we start the new randomized trial, that we saw that by validation, the slit lamp photos examined by 4 different people, unconnected to the real examination of the patients, were all kind of congruous. There are not many outliers. We also found that those who had a higher inflammation score are most invariably a gram-negative bacilli. In this particular case, it was Pseudomonas aeruginosa. We also, and we end the study, we also found out how the inflammation score and visual acuity measure. We found that as the inflammation score increases, logMAR vision also increases. That means vision actually decreases. When the inflammation score is less and your vision is more, logMAR score is less. So with that, we stop with this presentation, and I invite next speaker will be Jovita, I think.
So we have Dr. Jovita.
Yeah.
You want
So we can stop this particular slide and put on to Jovita's presentation, please. Thank you.
So Dr. Jovita will be talking to us about microbiology, including the testing, how they follow in assessing a case of endophthalmitis. Dr. Jovita is doing extremely, she is head of the department at LV Prasad, Hyderabad, and doing very extensive work, has done a lot of work on NGS, as you will see what she is presenting.
Thank you very much for the kind introduction. At the outset, I'd like to thank the organizers, especially Dr. Das, for inviting me to present what we do at LV Prasad Eye Institute in endophthalmitis. So, we all know that endophthalmitis in India is synonymous with Dr. Das, and so thank you, Dr. Das, for inviting me today to present our work. And before I begin this talk, I wanted to wish him a very happy birthday today. Coincidentally, it is his birthday. So when I Googled to know how old he turns today, this is what Wikipedia shows me. So I don't know if if Wikipedia is wrong or he was trying to fool the world with this date of birth. But I have authentic information from his wife that today is his real date of birth. So happy, Dr. Das, whether you are 75 or not, we wish you a very young and prosperous birthday. Okay, coming back to microbiology. Unlike when I present in front of the cornea folks, presenting in front of the retina folks always makes me nervous, because microbiology, I don't know how much relevant it is in front of retina surgeons, because you all have already injected antibiotics even before we begin microbiology. So most retina surgeons are so reluctant to even wait for the cultures and feel microbiology is just procedural. Most often, I often get fellows who come and ask me why are cultures negative when they even forget to send the samples to the lab. Between the OR and the lab, the samples are often lost. And very often negative cultures are blamed on poorly collected, poorly transported, sometimes non-existent samples. That is just the gist of it. But what we have to remember in this era is, along with direct observation and clinical features, today microbiology cannot rely on just isolation and characterization of the organism. Today we have to shift to molecular evidence. And I'm keeping this puzzle like this as still open, because there are still lots of answers and lots of clues that we do not know. Even in direct observation, microscopy is advancing. Even in clinical features, there are still lots of features, as Dr. Das has mentioned, how severity score can be a clue to the organism. Even in isolation and characterization, we probably are not using anaerobic media, which could be a clue to anaerobic organism. In molecular evidence, along with PCR, along with NGS, we probably should use other techniques to isolate other fastidious organisms. So the realm is expanding, and the future still will keep growing. So I'll take you back to a paper in 1999 from our institute, where this was what we published at that point, where the spectrum of postoperative endophthalmitis of gram positive was 46%, gram negative was 26%, and fungi was around 16%. Now, when you compare this with EVS and other studies in India, it was obviously different from the EVS, but more or less in India, all of us agree that gram negative and fungal did have a substantial percentage, though in varying numbers. Some of us had higher gram negative, some of us, like PGI, had higher fungal spectrum. And all of us across the country have tried to use an array of smears and an array of media, liquid culture, an array of fungal media, bacterial media, anaerobic media, and still the percentage of culture positivity ranged from 30% to 60%. But what has changed since then? In the last 3 decades, now this was a study which we published, in the last when we compared, okay, I'm able to see it, I don't know what happened there.
It's come, come.
Okay. So what has changed in the last 3 decades? What we can see is from 1991 to 2015, the culture negativity, while the positivity which was earlier around 45% has come down to under 30%, paralleled by a culture negativity increase, which is shown in red, from 50% to today over 70%. And this, I think, is true for everyone all over the country. So while the Western literature would term this culture negative endophthalmitis as non-infectious or sterile, we as practicing ophthalmologists know that that is not true in our scenario. You all are diagnosing them, you all know this is infectious. So why is microbiology labeling them as culture negative? And what are these reasons? There has been no change in the practice patterns in the last 25 to 30 years. Are pathogens getting smart? Or are we really making a clinical overdiagnosis? And I don't think any of you all sitting here in this audience believe that this is true. Are we dealing with sequestered, unculturable pathogens? Probably true, but we are not sure. So obviously we need a more higher modality of diagnosis. And that is where unbiased next generation sequencing today is now playing a major role. So what has changed in the last 3 decades is the advanced microbiology techniques. Today we just can't rely on traditional microscopy and culture, and we need molecular techniques like PCR, Sanger, and NGS in our spectrum. Apart from diagnosis, in the antibiotic susceptibility patterns, also what we have seen is over the decades, gram-positive, we have some solace there. There has been only a marginal increase in resistance for vancomycin, though for gatifloxacin there has been a sharp rise in resistance. But this is not true in gram-negative. In gram-negative, our primary empirical antibiotic of ceftazidime, the resistance has increased to over 65%. And this is alarming, and we should take note of this, because we should now need an alternative to gram-negative drugs. So in view of all of this change, Dr. Das has initiated an endophthalmitis management study, which is a multi-center prospective randomized clinical trial, of which the details he will probably be doing it in the next talk. So I'm not going into the details of that, but what we did in that study is for microbiology, along with culture and microscopy, all samples in that study were processed for PCR as well as NGS, next generation sequencing also. In addition, we tried for the fungal organisms that grew in that study, we tried to also do antifungal susceptibility by macrodrop dilution method. So the gist of it is that among the 428 samples that were included in the study over the 4 years, what was available for us for culture was 408. There were some reasons for which 25 samples could not be included, and what was available for PCR were 405. What was surprising was, if you remember the initial slide where I told you gram-positive was higher compared to gram-negative, now what we see is that there's a huge rise in gram-negative organisms. Today, gram-negative is 82 and gram-positive is 42, followed by a little bit amount of fungus and gram-positive bacilli. But the organisms, however, did not change. The names of the organisms, if you see, Pseudomonas aeruginosa, Staphylococcus epidermis aureus, Bacillus, and Corynebacterium, they were more or less similar. So while the organisms and the etiology spectrum did not change, the ratio of gram-negative versus gram-positive changed dramatically among the culture-positive bacterial endophthalmitis. So when we looked at the NGS results of the culture-positive, only 9 of the 200 samples did not match with culture. So with that confidence, we had the confidence to accept our NGS results and move ahead to look at the culture-negative samples. So when we looked at the culture-negative samples, we got the usual culprits like E. coli, Moraxella, Klebsiella, Pseudomonas, Staphylococcus. So we were surprised. Obviously, these are organisms that could have grown in culture. So probably, we being a referral center, it is possible that the patients who come to us are being treated elsewhere, and that's why, hence, they are not growing in culture. So there is no reason, we are not dealing with any unusual organisms that cannot grow in culture. So culture negative also has the usual culprit of organisms. Probably load is low, or probably they're being treated and hence unable to grow in our usual detection methods. Following that, we also looked at the susceptibility pattern, and what we saw was cefazolin was, we had 100% susceptibility, followed by vancomycin, which was equally good at 97%, followed by gentamicin and moxifloxacin in the gram-positive group. So while we are good in the gram-positive group, the gram-negative was slightly alarming. What we thought that imipenem would be good was actually not. It was colistin that showed the highest susceptibility at 89%, followed by amikacin at 78%, followed by ceftazidime at 70%, and imipenem at 66%. In our cohort, we also had 36% multi-drug resistance. Now, when I say multi-drug resistance, I mean more than 3 families or classes of antibiotics. Of them, among these multi-drug resistant organisms, 81% of them were obviously gram-negative and 15% were gram-positive organisms. Among the gram-negative organisms, all of them were resistant to almost all classes of antibiotics, but colistin was slightly superior than the rest. Among the gram-positive organism, only vancomycin, actually there were only 4 isolates, of which one of them was vancomycin resistant. Now, what was also interesting is, along with gram-negative being alarming, we did find fungal also in our acute post-cataract series. So we found 6 fungal culture-positive fungus which grew, and were predominantly Aspergillus and Fusarium. But apart from that, we did find 9 culture-negative fungus also, which were predominantly, again, Aspergillus and Fusarium, though there were 1 or 2 Candida species also. So what I'm trying to emphasize here is almost 1 in 10 acute cataract, post-cataract endophthalmitis can be a fungal organism, especially when it is culture negative. So do have a suspicion of fungal also. I'll be quick. When we look at the antifungal susceptibility, however, almost all of them were resistant to all the drugs tested, especially voriconazole. When susceptible, it was only caspofungin and posaconazole that did show slight amount of susceptibility. So maybe it is also time to look at newer alternatives like caspofungin and posaconazole, whether they can be used intravitreally also. Amphotericin B did show to be slightly better than voriconazole. To summarize them, among the 428 patients that were recruited, culture positivity that we saw in our study was 31.5%, but when we included PCR and NGS, the culture positivity, the microbiology positive samples improved to 61%. So that brought us to our original 3 decades back percentage of positivity that we used to see before. So to summarize, what I would like to say is culture plus microbiology using NGS, the positivity improved to 61%. There was no susceptibility difference between ceftazidime and imipenem. Colistin proved to be superior than ceftazidime against GNB. But one point to note is that the GNB resistant to ceftazidime were susceptible to colistin. So probably we could use for GNB a combination of ceftazidime along with colistin. 1 in 10 cases of culture positive acute post-cataract endophthalmitis could be a fungal infection in our country. And finally, next generation sequencing is here to stay whether we like it or not. I have to thank my group for this entire study, without whom nothing of this would be possible. Thank you.
Jovita, can I ask you a question?
Yes.
This is, we have now newer ways of diagnosing from culture to PCR to the NGS. Now, when we look at it from many of these cases, we as a prior practitioner, we may be concerned what is the medico-legal importance of it. Now, supposing I do culture and I do not do NGS or I do not do PCR, what is the status medico-legally versus if you do everything, what happens? You know, are we supposed to, is an NGS analysis acceptable medico-legally, or culture is still the gold standard?
I think when you look at it medico-legally, it is still in the context of suspicion of an infection. Any of us do not do a test without a suspicion of an infection. So every time we always write the underlying statement is correlate clinically. So the medico-legal case will have to lie with the ophthalmologist is to correlate it with the clinical scenario. Whether you accept that
I think
diagnosis.
culture, PCR and NGS cannot fall into legal framework because of not widespread availability. Because once you issue guidelines on behalf of any society or whatever, you have to make minimal possible, not the maximal or most sensitive part. If you include PCR or NGS into it, then it may create an issue also. And most of the treatment is empirical only to begin with. Only thing what I would I wanted to compliment Dr. TP and the LVP group is, you see, most of the people in the country still follow EVS, which is more than decades and decades old, 25 years back. So I think there's a need to change. There's a need to change, like you rightly highlighted, but only that colistin should be substituted to ceftazidime. The only thing is, why did you say that both can be done, colistin plus cefta?
So CLSI guidelines say that colistin is your last drug, last resort drug. So they in fact advise not to use it alone. They say that it should be used in combination with any other drug.
The reason I'm asking you,
but this is again for systemic. This is not an ocular guideline.
The reason I'm asking because I want to take guidance from sir also, that because we are in the process, for a long time back, we have been issuing, the charts from CIPLA and other companies for the mass dissemination. So yesterday only I visited that place and there was a need to revise these guidelines. So I'll ask and take guidance from sir, should we now say vanco colistin as first line if you are gram negative, or as second line?
No, I agree with you, Lalit. But in answering question of Ajay first, that currently still culture is the gold standard, even though it is lowered down, 30–40% only are culture positive. The reason is that they are the only time you can do a susceptibility testing. PCR, you can't do a susceptibility testing. NGS you can do, but NGS does the ARG, antibiotic resistance gene, not susceptible gene. So I will still say culture is required, but someday it will change to NGS, even skip PCR actually. Coming to question number 2, whether it should combine or not combine, or shift or alternate to ceftazidime. I know that most of the people working in Delhi do not give ceftazidime anymore. It is mostly either imipenem or piperacillin tazobactam. And Jovita's contention is that what he told for last drug, I will anyways talk about that in my presentation next, for systemic, not for intraocular. Systemic colistin is 9 million per day. And what to give colistin inside the eye is 1,000 unit intravenous units one time. That is 1/9,000th of required drug systemically, and 2, half-life of colistin only few hours, 3.5–4 hours. So how will it go actually enter the systemic circulation to cause resistance? But that is debatable. Just because somebody said, I will not believe it. Also, to this audience, I will remind you that all of us give ceftazidime as a drug of choice for intravitreal first choice. It was not tried. When we talked evidence-based medicine, EVS tried on amikacin as a drug with along vancomycin, but changed to ceftazidime because amikacin is found to be a macula toxic, retina toxic. But nobody has questioned this, that did you try ceftazidime? I'm not questioning the wisdom, but then certainly say that is not the last wisdom all the same time. So I think I'm happy that my team helped me to do this last study, and then hopefully VRSI, AIOS, everything will rewrite the guideline to what is applicable to us or to South Asia compared to what is applicable to Caucasian population.
So my question still remains unanswered. What should be the first empirical choice?
We have changed actually. We have changed, but then unless you do another experimental study or animal study, you can't say.
You have changed to?
We have changed to colistin or imipenem, etc.
Venco plus.
Plus, yeah. Venco still remains very good.
Venco remains supreme.
Incidentally, Venco is also last drug to be used for gram-positive cocci infection. We'll just quickly go. Thanks, Jovita.
Yeah, thank you.
We have talked about what happens when a culture is negative. And there are, Ajay will talk about approaches and options on culture negative, and you do not have options of doing higher molecular microbiology maybe. And patients, how does it guide? And followed by, I will request Lalit to speak about, ahead of me, to talk about how to prevent endophthalmitis by either topical application of or intracameral injection. Is okay, Lalit?
No, I thought first I will cover up TAS and differentiate what you spoke about diagnosis.
Then I will talk before you?
Yeah.
Okay, I will talk after.
अमित आ गया आ तो गया था
So can I, yeah, thank you very much. So at the outset, I must thank AOS and Dr. Das for including me in his masterclass. It's an honor for me. And one of the cases which I'll be presenting here, I have actually been, connected.
One point I would like to add in the previous talk, that always use
Connecting with
moxifloxacin,
him.
which is preservative free.
So
Sometimes people take moxifloxacin which has preservative, then it can cause tox.
So this, I will be presenting on culture negative approach and options and some interesting endophthalmitis cases. So the incidence has gradually been increasing, as Dr. Jovita said. Why this is happening? So the incidence is gradually is increasing, and the reported incidence is 30 to 70%. But the incidence of culture negativity, as Dr. Jovita said, has come down to as low as 30%. The culture positivity has come down to as low as 30%, and negativity is almost 70%. What are the reasons for culture negativity? It could be prior use of antibiotics, scant or fastidious organisms, immune reactions to these organisms, a capsular bag sequestration, sampling errors, or maybe a sample has never been sent, as she pointed out, TAS or a masquerade, and unculturable organisms or the newer organisms that are being discovered. So we now have better methods of identification of organisms. One is by the PCR with Sanger sequencing and NGS, and I'll be showing you how we used NGS, the Oxford nanopore sequencing, in our case series, and that still was negative. So this is a little busy slide, but the key points of culture negativity, as I said earlier, is that we have to make sure as to why in particular cases the negativity is coming. The approach for any endophthalmitis remains the same. What I follow now is we take two samples. If we get adequate amount, we divide the sample into two. Sample 1 is for smear and curettage and culture identification, and sample 2 will either go to PCR or NGS, so that we can cover up all the aspects. And this of course means that a lot of money may need to be spent, but it's worth spending it right in the beginning so that we can treat our patients better. So I'll be showing you two cases which will tell you how culture negativity is there. So this is a 63-year-old diabetic female, and I now have a 11-year follow-up on this patient who had received 14 injections of vancomycin and ceftazidime, multiple injections of Avastin, because it was considered probably because she she was also diabetic. She got methotrexate. She was PCR and culture negative. She was PET-CT negative, and she was cytology negative. So when she came back to us, and this patient was from Chandigarh, and I was operating in Chandigarh at that time, so she worsened and presented in August 2015 with a visual acuity of 6/24. We stopped all the systemic and topical antibiotics. This patient had a well-centered IOL, and I told her that we might want to remove her IOL. Her visual acuity was that time 6/24, but she refused to get her IOL removed despite suffering for 5 years. So the question now was, should we continue giving the intraocular antibiotics and steroids, or can we do something else? We needed to have a sample. So what we did is, I tried to modify it. I thought that there could be a way of getting samples from the zonules because she had undergone vitrectomy. So we modified the thoracic 26 gauge needle, and you will see here we took the samples from the angle and samples from the zonular area. This was then sent for PCR as well as exciton, and this is just to show you the same thing. And the PCR was done at SN and exciton was done in Bangalore, and we had this P-acnes from the PCR, and exciton shows fusarium. So this is just to show that there could be, so who was right, who was wrong, we didn't bother about it. We treated both. We treated with vancomycin as well as voriconazole, both intravitreal as well as oral voriconazole, and patient till I last communicated with her till about COVID, and we probably lost her in COVID, and she was doing well for almost 4 to 5 years. So what happened, I don't know. This is case 2. This is a 34-year-old male diabetic, IDDM, who had VR surgery done, was culture negative, and he came to us after having undergone SOR. He developed a very severe throat infection, and following a throat infection which was mucopurulent, he developed probably an endogenous endophthalmitis. Some people may say that it was actually infective endophthalmitis, and this is just the sequence of things which I'm going to show you. He underwent vitreous lavage and vanco with the Tazobec and Decadron. So this is the sequence of events that occurred to him over a period of time. On 13th June, he had a repeat surgery. This is how initially the fundus was not seen. You can see the fundus now. The visual acuity improved to 6/6 until now. When I saw him last on 29th August, he was doing well with a good visual acuity. So this is the sequence of ultrasounds for this particular patient. When he presented to us on 2nd June, he had, this is a vitrectomized eye, so he had this opacities of moderate intensity. And then he subsequently underwent vitreous lavage, multiple drug injections, which included vanco, Tazobec, and on the second time he underwent injection of colistin. I also did a wash with betadine, and the patient is doing well. He still till today has few vitreous opacities. I don't know what the cause is, and we have stopped all treatment for him. His visual acuity is 6/6, is doing well. So this was a case of culture negative endophthalmitis which received multiple antibiotics at one go, which Dr. Lalit asked, can we combine more than one drug? Yes, in some cases of severe endophthalmitis, it may be necessary to combine more than one drugs to get the desired effect. So in the end, what I would like to say that next generation sequencing is there to stay. We have to judiciously use it. organismal diagnosis is important and helpful. And case 1, you saw that despite the PCR and NGS, we could have, that time NGS was not available, but PCR and culture gave us a diagnosis and we were appropriately able to treat. So sampling of the correct sample is important, and in the second case, as I showed you, that use of multiple drugs, use of betadine lavage, and a close long-term follow-up in these cases is important. So you must start with empirical treatment, which at this point of time may be vancomycin and tazobactam for me. Later on, I may add colistin. There should be a timely and a judicious use of appropriate antibiotic, timely intervention with the vitrectomy, and we must be aware of the bacterial resistance. So therefore, we must be ready to change the antibiotics. Thank you. I have some interesting cases which I think I'll show later.
Thank you, Ajay. Can you go back to my slide? Which can open up again. Thank you, Ajay. I agree that culture negative is very more in number, either because you are not able to culture it or the organisms are getting smarter. We'll talk about that evidence-based medicine. It's not working, not moving. Hello, it is not moving. It moved. Till now, we are dependent on a very important real path-breaking study called Endophthalmitis Vitrectomy Study, EVS in short. It was published in 1999, Archives of Ophthalmology. Now it is renamed as JAMA Ophthalmology. It talked about this is a typical 2x2 study where it said that should or should not use vitreous biopsy or vitrectomy immediately, and should or should not use systemic antibiotics. And he gave two important information to us. One, that vitrectomy required only when visual acuity is poor. Poor, the defined, even defined hand motions or loss, like light perceptions or less. Also told that systemic antibiotics do not add benefit to the entire stuff. Also remember that recruitment-wise, EVS recruited enough eyes where the cornea was clear enough to visualize. Actually, in practice, as we saw some of my actual practice in my India or in my presentations, that doesn't always happen. The cornea is always clear to do a vitrectomy, because today we can do an endoscopic vitrectomy if the cornea is not clear. Legacy-wise, EVS had a huge legacy. For the first time in the world, they put a level 1 evidence of managing post-cataract acute bacterial endophthalmitis because they did not have any fungi. And 2, it reduced economically both for the provider like us and the patient, because reduced hospitalization, only injections, don't have to stay in hospital and don't have to have a systemic therapy. But within 10 years of this publication, many publications start appearing that questioning is the EVS the current thing. It started with the Farang-Kuhn, that endophthalmitis vitrectomy study is relevant after 10 years of his publication. And finally, year for last published from United States, asked EVS guidelines still valid. In between, Grabowski from Poland and we from India keep on questioning that should EVS guidelines be relooked. Why should we relook is, one, between 1990 when EVS started, 1990 to 1994, technology of vitrectomy has improved significantly from large gauge to smaller gauge and the better fluidics and lighting condition. Microbiology, as Jovita told, has already increased tremendously both technique and technology-wise, and also Ajay told about the gram-negative infection. And third is that this also Jovita showed that resistance of commonly given antibiotic, particularly ceftazidime, has increased tremendously. We also saw that the spectrum of infection reported either in USA EVS or Europe ESCRS were different than India. In India particularly, we saw that gram-positive cocci are much less, 53% compared to 90+% in Europe or America. Gram-negative bacilli is much higher, 26% compared to 6% in EVS, and we have a fungal infection whether you like it or not. Not only we but also came from China and Singapore, that the spectrum of infections are different, which means that your management has to be different than what was always proposed by EVS in 1995. So we have three important research questions. Should the presenting visual acuity be the sole criterion for choosing empiric treatment? Because you can't get a culture report immediately, you have to start the empiric treatment whether you like it or not. Two, shouldn't new technology be added to the lab workup, like Jabita told about, or Ajay told about PCR and Sanger sequencing, next-gen sequencing. And third, because of growing antibiotic resistance, particularly for gram-negative bacilli, so there is alternative to ceftazidime. We answered all these questions by, one, we tried inflammation score instead of visual acuity, which I presented first time. And two, we also use Sanger and next-gen sequencing for microbiology work. And three, we choose two antibiotics, imipenem and colistin as alternative to ceftazidime, and design this large study. It's registered on the clinical trial register of India. We just December this year we finished, last year we finished. We are now in the stage of analyzing the data. As you also, when you said inflammation score, we revalidated it, even though we used it in 1990 in our DEXA endophthalmitis study. And then we choose these are the drug combination which we use for EMS. For particularly fungal infection, we had choice between amphotericin B of voriconazole, natamycin topical, and systemic itraconazole. In variants to the EVS, we always use intravitreal dexamethasone because we found very useful for bacterial infection in India. And two, we use the oral ciprofloxacin, 750 milligram twice a day for 5 to 7 days, because cipro has got a good vitreous penetration compared to then used vancomycin, amic acid, and ceftazidime. This was done a multi-study randomized clinical trial in 3 adjoining states of India, Telangana, Andhra Pradesh, and Orissa. 3 states, 4 large tertiary centers and 20 secondary centers. 432 patients recruited. After 21 patients did not have a regular follow-up at least for 3 months, to exclude them. Ultimately, total 411 patients, and everything is shown there. By B-scan, which Ajay showed very beautifully, 99% had some kind of echoes. Some kind of echoes, and 53% had no glow of the vision. That means this all guys was so-called severe. At the same time, 1.7% patients also had a vision of visibility of third-order vessels. Visual outcome after treatment, as we explained in our randomized clinical trial protocol, 1/4 of them, 25%, had a good vision, defined at 20/40 or more. Half of them had a navigational vision, and 2/3 of them had a ambulatory vision. At the same time, we could not save 1/10 of the patients. We also saw that by logMAR vision keep on improving after treatment from 2.2 to logMAR, which is that means very bad external vision, to improving to 1.29. Also, inflammation score reduced from 14.41 average to mean to 2. As Jovita has already shown this, that culture positive was less, but then NGS positive was 61%, fungi were 12% in our patients. And this was repeating what Jovita told, that all culture negative but not necessarily organism negative. So we defined a new term called a micro-negative, which is culture, micro-positivity culture plus sequencing, or micro-negative culture plus sequencing. It was all the negative bacilli, organisms were actually positive bacteria or the fungi. We also found in the culturable organism, 39 or 40% of them had multi-drug resistance. Most of them were gram-negative bacilli. This is already shown that Vanco was better than other drugs. Similarly, colistin was better than other drugs for gram-negative organisms. We also found, interestingly, that those who are resistant to, those gram-negative bacilli resistant to colistin were sensitive to ceftazidime. Actually, that raises an important question, that we are not able to identify proper or do not have an immediate immediate microbiology facilities should combine ceftazidime vancomycin so that the patient doesn't have to require second injections or through. Colistin prepared this way, 1,000 units. It comes in a 100,000, 10 lakh vial, then you dilute 2 times to get it 100,000 international units. This is what Jovita is talking about, very important for me. CDC says that both vancomycin and colistin are the last drug. Vancomycin for gram-positive cocci, colistin for gram-negative bacilli. But this is for systemic therapy. Look at that therapy part. Intravitreally, you give 2-gram dose every day for vancomycin for at least for 6-7 days. And dose vancomycin is 1-2,000, most probably 1 or 2 times, with half-life of something like 3 days for vancomycin. Colistin, half-life is very short, 3.5 hours. You give 1/9,000th required for a per-day injections of colistin, to my mind, because endophthalmitis is a serious disease. Empiric treatment is standard of care right now. Can't wait for the culture, because by the time culture report comes, your eye might be lost. And true intravitreal half-life is so low that most probably it may not cause any systemic problem. With this, I stop, and then I invite Professor Namrata Sharma to talk about how to prevent bacterial, at least bacterial endophthalmitis. Namrata. Can we just come out this and use her computer, please?
Thank you. Thank you. I would be speaking to you about prophylaxis of endophthalmitis. And there are no direct लगा दो इधर HDMI direct है. I would like to thank Dr. Tara Prasad Das for agreeing to come here to conduct this masterclass, and I think it is a very important masterclass because it is related to endophthalmitis, and given the body of work that has been done by LVPI and SIR, so I think it is going to be very useful as far as endophthalmitis is concerned. I am going to be talking about prophylaxis of endophthalmitis, and there are no financial or proprietary interests. And in the current times, if you look at the previous times, the incidence has decreased from 1 to 0.05 to 0.1% over the last decade. It can of course be of 2 types: sporadic, when usually contamination occurs from the patient's own conjunctival flora or deficiency of aseptic protocols, or it can be cluster endophthalmitis, which is usually due to a sterilization failure or contaminated surgical supplies. I think this has been very nicely covered by Dr. T.P. Das sir in the recent survey. This is of course a report which was not recent, and gram-negative and fungal infections are increasingly being increasingly encountered in our country. So as far as the preventive measures is concerned, the pre-op topical antibiotics most people do give, but I think the mainstay for prophylaxis is povidone iodine instillation in conjunctival sac for 5 minutes. Intraoperatively, people have tried intracameral antibiotics, and of course, post-operatively, the topical antibiotics can also be given. So the types of antibiotics which can be given preoperatively include fluoroquinolones, aminoglycosides, cephalosporins, even chloramphenicol. The route of administration could be topical, intraocular, subconjunctival, or oral. And the timing could be pre-op, intra-op, peri-op, and post-op. So the prophylaxis of endophthalmitis begins right from when you decide to do the surgery, and it is important to look at the various measures in the operation theatre layout, the patient screening and precautions, general examination, ocular examination, the OT preparation, as well as the post-op measures. Presumably, all operation theatres would follow the protocols which have been given for good OT etiquettes. And of course, we do require dedicated functional eye care facility, a separate emergency OT and a separate septic OT. And all the zones, level 1, level 2, level 3, and level 4 should be followed. Preoperative practice do play an important role, so it is important to do a good general examination, a thorough checkup. The BP should be less than 160/95. The blood sugar, fasting blood sugar, classically less than 140, postprandial less than 200, and of course glycosylated hemoglobin also has to be seen to see the 3-month control. ECG, urine analysis, and then one has to also look for systemic illness like diabetes, cardiovascular condition, renal conditions, hypertension, and if required, a physical consultation may be sought before surgery. Again, important to do a good ocular examination, not only for all patients, but especially for one-eyed patients. Intraocular pressure has to be checked. The patency of NLD and negative regurgitation test should be ascertained. Syringing is classically not done on the day of the surgery. Adnexal infections to be treated with systemic antibiotics. Lid conditions and sac-related conditions such as entropion, trichitis, and dicrocystitis should be treated first. And intraocular surgery can be delayed by 3 weeks after these surgeries, and all investigations, including the contact biometry, should be done at least 1 day prior to the surgery. Avoid any contact procedures on the day of the surgery. So preoperatively, the topical 4th generation fluoroquinolone can be started in both eyes 4 to 6 times a day, at least 1 day prior. Written informed consent should be obtained in all cases after explaining procedure, and also the risks which are involved, and ocular and facial hygiene is also very important. We should follow the etiquettes for washing, scrubbing, as well as for gloving, and correct techniques should be followed which have been laid down. Then during surgery, I think the biggest precaution that is required is on the wounds. So wounds which are unstable and leak should be sutured to avoid hypotony. Topical fluoroquinolones to be instilled in conjunctival sac, and intracameral antibiotics should be given in all cases, or at least in complicated cases. Again, after the surgery is done, proper lid hygiene has to be maintained. Topical fluoroquinolone should be given for 7 to 10 days. Topical steroids in tapering doses for 6 to 8 weeks, and that's why I don't like to combine steroids with antibiotics, but like to give it separately. Because if you give antibiotic steroid combination and try to then taper it, then chances of resistance developing are much higher, because antibiotics should be stopped short and should not be tapered. Cycloplegics if required, and wear protective dark glasses outdoors in the early post-op period. Regular follow-up is very important, first post-op day, 2nd or 7th day, and then month 1, and then depending upon as and when required. Emergency consultation should be sought whenever there is any pain, redness, watering, discharge, blurring of vision, floaters or flashes, and signs such as congestion, hypopyon reaction, or reduced fundal glow or vitreous exudates. Now, coming to intracameral antibiotics, the rationale is that the corneal incisions may permit influx of the fluid during surgery, even after hydration of the main incision in the side port. And in spite of using pre-op antibiotics, povidone, iodine, the rate of the intraocular bacterial contamination may be still increased. So when you inject the antibiotics intracamerally, you actually intend to kill the bacterial microbes that have been introduced during the procedure. And the posterior capsular tear is one of the strongest risk factors for infectious endophthalmitis. Now, in the AIOCMTC4 survey in 2021, 66% of the respondents and the members said that they do use intracameral antibiotics. And the increased adoption of intracameral prophylaxis increased to 93% in this particular survey. So cefuroxime, moxifloxacin, vancomycin, and cefazolin are the 4 antibiotics which are available and can be given intracamerally. The advantage with moxifloxacin is that the preparations are available commercially, apart from the fact that it does give a wider spectrum of action. So the first study that was done was the ESCRS study for prophylaxis of post-op endophthalmitis after cataract surgery, and they saw that there was 5 times reduction in the rate of endophthalmitis. Of course, compounding it in pharmacy is a major problem. Vancomycin was also used intracamerally, but the concern was risk of hemorrhagic occlusive retinal vasculitis, which was reported, and this seemed to have results which were not acceptable. Intracameral moxifloxacin, especially the preservative-free moxifloxacin, is being used in dosage of 500 microgram per 0.1 ml. And if you look at the efficacy, in this retrospective study from Arvind Eye Hospital, 1 lakh plus eyes, there was 4-fold decrease in endophthalmitis. And in this, again, retrospective study, 6 lakh eyes, in the endophthalmitis decreased by 3.5 times, and more so in cases where posterior capsular rent was there, because chances there of endophthalmitis are far more. Again, from the Japan, similar findings were reported from 19 clinics. This was a case to look at the safety of intracameral moxifloxacin. Endothelial cell loss and pachymetry remain unaltered. And again, a randomized trial which concluded that there was no problem as far as visual acuity, IOP, or endothelial cell is concerned. This was the first survey that we did from All India Ophthalmological Society under the guidance of Dr. T.P. Das, sir, and this looked at 4,292 respondents. And there were differences in the sense that there was similarity in decision for pre-op and post-op antibiotic and intracameral antibiotic as far as the survey, AIOS survey and ASCRS survey is concerned, but there was dissimilarity in the choice of intracameral antibiotic and decision for subconj antibiotics, because from the AIOS, subconj antibiotics was still being used, which of course I think they have decreased markedly now, and cefuroxime was not being used by AIOS members. Now again, more than 9 lakh eyes again showed that the intracameral moxifloxacin should be used. This was the second survey, which again showed that the choice for moxifloxacin had increased from 40% in 2017 to 58% in 2022 intracameral use. And we actually did a randomized control study, because there's no prospective randomized control study with good adequate power in terms of statistics to show whether it works or it doesn't work. So we used 500 microgram per 0.1 ml, and we studied this, evaluated this in a large cohort of 60,000 eyes, recruiting 30,000 in each of the groups from 3 tertiary eye centers in India. Between June 2018 and 2024. There was a hiatus of 2 years because of COVID, so we had to stop this study in between. But we looked at all cases undergoing phaco and intraocular lens implantation more than 40 years and who followed up, divided into 2 groups with intracameral moxifloxacin and without intracameral moxifloxacin. And post-op, of course, we continued our routine regimen of post-op antibiotics. Whenever a case of endophthalmitis occurred, protocols as per the management were followed. In terms of age, gender, visual acuity, IOP, endothelial cell loss, central corneal thickness, the 2 cohorts were comparable. So also the intraoperative parameters in terms of incision size, type, location, IOL, position, haptic, optic, type, wound closure, and also posterior capsular rupture. Now, the odds of having endophthalmitis in those cases where intracameral moxifloxacin was not given was 2.5 times as compared to those where it was given. So 6 out of 6 eyes in one group and 16 eyes in the other group did develop endophthalmitis. And again, when we looked at the, in terms of post-op endophthalmitis, when we looked at the various parameters, these are in both the groups as shown. So 2 eyes in the intracameral group and 6 eyes in phaco alone group were culture positive, and of course resistance to fluoroquinolone was there. 2 of the 7 eyes where phaco alone was done. In terms of, again, safety parameters, there was no difference between the 2 groups. and this has got accepted last week only in Journal of Cataract and Refractive Surgery and will be published soon. This was the drug that we used. And having said this, there is a ASCRS advisory, and that is that there are two different concentrations available, 0.5% and 0.1%, and we have to use the correct concentration and the correct dose. So to conclude, intracameral moxifloxacin is safe and efficacious in prophylaxis of endophthalmitis after cataract surgery, but of course we have to use antibiotics pre-operatively and post-operatively. So thank you very much for your kind attention.
Thanks, Namrata. Wonderful. Actually, good to prevent endophthalmitis than cause and happens and treat it. Incidentally, we also did a wonderful prospective study about comparing moxifloxacin intracameral and cefuroxime in our all secondary centers LVPI system. We found that both are equally efficacious, but in India, I will suggest moxifloxacin because it is easier to get and easier to, don't require dilution at all. But problem is this, someday both cefuroxime and moxifloxacin start being resistant. At that time to find out, be prepared for that, to find alternative to those intracameral injections. So this will invite Professor Lalit Verma to talk about the current practice pattern of prophylaxis. And with this also we'll stop because of paucity of time. We'll not go beyond this, but I will, after Lalit speaks, I will expect that many of you will have some questions, comments to answer, to ask so that we can, some of us can answer these questions. Lalit, please.
Thank you, Professor Das. And at the outset, I must compliment Professor Das, Professor Joseph, and the entire LVP group for such a nice work they have done. Connector हमें लाना पड़ता है. All of us should be carrying the connectors because audiovisual team may not provide connectors. लगाओ, आ रहा है? आ रहा है कि नहीं? Very bad, yeah. बहुत ही गंदा. ये तो आ जाए, उसमें कुछ नहीं होता, वो बाद में भी आ सकता है, उससे फर्क नहीं पड़ता. आ रहा कि नहीं? चलो, यानी कि I'll speak like this only because of shortage of time. because 4 बार connector change हो गया, but nothing. In any case, forget it. Okay, touch, बस हाथ नहीं लगाना. So, Namrata presented wealth of evidence about prevention, but believe me, despite whatever anybody does, people still have endophthalmitis. So aim is to minimize. Even EVS study, done in 1995, collected 420 patients. So a lot of things have been emphasized, but I think level 1 evidence is primarily for betadine, draping of lashes, and good wound construction, because there are no substitute for these things. Intracameral antibiotics cannot take care unless until these things are done. So that's an additional prophylaxis. And Namrata has presented wealth of evidence, even though 6 and, how many patients in other group were? 6 and 16. If not, then prompt treatment is the answer. And prompt treatment, I am very happy to be part of this, exercise where our Professor TPD has, educated everybody here that, the ceftazidime, which we have been propagating for decades now, has lost its sensitivity for gram-negative and instead should be substituted with colistin or imipenem. And I would take his help to revise the guidelines of whatever we have done in the past. So, but other part which was there that what TPD had covered in the beginning about diagnosis part, this chart we had devised long time back, where this may help you to distinguish between TAS and infection if in the gray zone areas. Most of the times, a clinician, you can differentiate between TAS and infection, but if not, you see there are certain points like lid edema and chemosis usually do not occur in TAS at all. Then corneal edema is limbus to limbus always in TAS because it's a toxic endothelial reaction. Then IOP is generally not raised in infection because of cyclitis is generally on the lower side, whereas in TAS it may be high or normal also. And culture, a lot of things have been spoken about culture. And I will just finish off by saying that whensoever in doubt, whenever patient complains of unusual pain or decreased vision after initial gain, and lid edema, chemosis, haze, hypopyon, if in doubt, I pay a lot of attention to the color of vitreous opacities which you see. If you see yellowish color there, then think always of infection. But still, there may be some gray areas, I think, then are always on the side of infection, because no eyes have been lost in case you give intraocular antibiotic even in a suspect patient. So this is what I thought I'll share with you, and these are some 10 tips which we at our center had devised. Always suspect whenever there is unusual reaction. Very important is talk to patients and relatives, and promptness is the answer whether you give intraocular antibiotic or vitrectomy. Very fast you have to act, otherwise you may lose the eye. And pay a lot of attention to culture sensitivity, what Dr. Joseph had said about emerging ways to do it. Then don't hesitate to refer to higher center. And very important thing not stressed is document. You see, even if the eye may go into phthisis bulbi in your hand, but if you have documented that you have given antibiotics or referred to higher center, you still cannot be penalized in court of law. So this is what, sir, I wanted to share.
Thank you, Lalit. Most important to my re-stress that document very important, not for the medical legal point of view, but also to find in your hand, your organization, your environment, how people are behaving. Thank you very much for coming. Time constraint, but still I might say that Namrata might allow us 1 or 2 questions, if there is any. If none, is fine. Looks like there is none, so thank you very much for coming to this morning session. And while we all of us hope that we will not have endophthalmitis to treat. Thank you.
We can have a quick photograph of the group. Yeah.
Oh, photograph. Okay. Take your connector.